and they will also discuss our ongoing adaptive clinical trials and how they are helping to inform us and to take better care of our patients. After they offer their remarks, we'll take your questions. Dr. Yealy.
Thank you very much, Paul, and thank you all for showing ongoing interest in the pandemic and the UPMC experience with COVID-19. As we've been saying for many months, COVID-19 came to all the communities that we serve here at UPMC, and it's not going away. Everyone, that's all of us in our communities, including the medical professionals, is learning how and adapting to living with this virus, something that we will continue to do for many months. As you'll soon hear from Dr. Marroquin and Dr. Angus at UPMC, we are learning while we deliver care to you and to your loved ones. And we're learning fast, which is helping to improve our outcomes for all of our patients. Key measures, including the UPMC COVID-19 test positivity rates, the amount of time our patients spend in the hospital, their need for intensive care, or the use of ventilators, and those are machines that help you breathe, and the death rates are all far lower now than they were earlier in the pandemic. That's very good news for all the communities we serve in Pennsylvania, in New York, and in Maryland. It isn't a victory declaration, though. It shows that we can impact this infection with our actions, and that includes not only you in the public, but healthcare providers. Why are we seeing these better results today compared to what we saw in March and April? Well, first, we have better treatments, including steroids, and more effective clinical protocols. And we know better how to use all of the care steps for patient care, including positioning and breathing support. We are seeing from our own data, as well as data from other locations, that suggestions exist that the virus is changing in important ways. People are now experiencing less frequent bouts of severe virus impact. Perhaps that means that the virus is less virulent than we once thought or experienced. That doesn't mean that we can all go back to normal as we knew it before COVID-19. Wearing a mask as much as possible, keeping distance whenever possible, staying home when you're sick, and washing your hands frequently remain critical to keeping this virus in check so that we can reopen our businesses and our schools as safely as possible. We thank our dedicated staff and, more importantly, all the communities that we live in and we serve for taking these steps. You followed public health guidance, and you demonstrated that we can care about ourselves and about each other. We can't predict what the future holds for this virus in terms of its spread and its severity, and especially as we enter the flu season and we spend more time together indoors. What was key, what is key, and what will continue to be key is clear. Wear a mask whenever you're near others, and wear it correctly. Cover your nose. Secondly, make sure that we all protect those who are vulnerable. This virus looks for the most vulnerable. Keep them safe and be safe around people who are vulnerable. That includes the elderly and those who have conditions that affect immunity, their heart or their lung functioning. These actions will help us sustain and improve our collective COVID-19 experience. And if we all do these actions, we can avoid impacts of broader closures of our workplaces, businesses, schools, and other activities. At UPMC, we remain committed and vigilant to be prepared to care for all of our patients and our staff should the virus surge again. We will do all that is necessary to make sure that we can treat you, no matter what your healthcare need is, and we can do it safely. We will also create the new knowledge and the new care processes that will help now and will help moving forward. You expect this from a world-class medical center, and we'll deliver it. Excellence in care and in innovation. That excellence includes approaches to testing. While many push for expanded use of new rapid tests for the virus, we use an approach that is based on the facts and the science. We need fast and reliable tests to contain this virus, just as we need to develop safe, and reliable vaccines. And we will fully evaluate any new rapid tests to make sure they meet both of those criteria before adopting them. Now Dr. Marroquin will explain in more detail what our clinical data are telling us about what has and hasn't changed since the pandemic began.
Thank you, Dr. Yealy. As Dr. Yealy explained, the clinical data we have tracked and analyzed closely throughout COVID-19 are showing us some important lessons about how to better manage this illness. Let's start with testing. While we all wish that we could do more, we are in fact testing 2.5 times more COVID patients per day in the last 2 months compared to the prior period. And the test positivity rate is only slightly higher at 5.28% currently compared to the spring, which was 4.94%, suggesting that the people we serve are mostly taking the right precautions to protect themselves. While our testing has grown dramatically, our number of hospitalized patients has not. The average daily number of patients hospitalized with COVID-19 since July is approximately 2.8 times higher than in the spring. But daily discharges are 3 times higher. Our discharges are outpacing our hospitalization rates. Patients are getting better, and they're getting better faster, at least a day faster, as a matter of fact, than before. The best news of all is that in-hospital mortality rates are trending down. Surprisingly, the patients whom we admit are not much different than those we treated earlier in the pandemic. That is, current patients are similar in age and have similar comorbidities like diabetes compared to those hospitalized in the past. So why are the outcomes better in the past 2 months? We think part of the answer lies in the way that we have changed our care for these patients as we've learned more about this previously unknown disease, as Dr. Yealy noted earlier. For instance, our data show that more than half of patients since the end of June have received dexamethasone or other steroids, while the use of remdesivir has declined. And we are more judiciously using mechanical ventilation. These are just some of the factors at play in this incredibly dynamic disease. We continue to gather data and refine our analysis so that we can continue improving care and outcomes for our patients. Dr. Angus will tell you more about the lessons we have learned, particularly through our leadership in rigorous and adaptive clinical trials.
Thanks very much. So as Dr. Marroquin just told you, our data show that we're learning how to do things better over time, and maybe also the disease itself is changing. I'd like to report some positive news from our global REMAP trial. A commonly available, inexpensive class of drugs called corticosteroids, we have found considerably reduces the odds of adverse outcome, death, and/or duration on life support in critically ill COVID-19 patients. These results, coupled with those of other global corticosteroid trials, were published yesterday in JAMA, or the Journal of the American Medical Association, and in fact also led yesterday to the WHO to issue new updated guidelines in this regard. And it's important to note we were delighted not only to be involved in the leadership of the REMAP trial, but to have UPMC actively participating, and we had a significant number of patients from UPMC hospitals participating in this trial. I spoke once before about REMAP. As a reminder, REMAP stands for a randomized, embedded, multifactorial adaptive platform, which is a new kind of way of thinking about doing randomized trials. The gold standard for testing whether a treatment actually works has for a long time been the so-called randomized clinical trial, or RCT. But the way in which we've done RCTs has traditionally been to look at one treatment at one dose at a time. Every patient is randomized 50-50. That's sometimes something that someone doesn't necessarily want to participate in. And furthermore, it can take months or years to get to an answer. What we want to do is think about trying to generate just as robust information, but do it more quickly and do it in a way where patients have a greater chance of benefiting. So REMAP is designed to simultaneously test multiple combinations of potential therapies at the same time, and this increases the efficiency and the speed with which we generate information, which is always valuable, but particularly valuable during a pandemic. And so, for example, within our current REMAP-CAP COVID program, we've actually been testing multiple different treatment regimens, including various doses and combinations of even simple things like vitamin C, but also convalescent plasma, blood thinners, antivirals, and other drugs. The other thing that I just want to remind you all, we were involved in the design of REMAP, and we've been very vested in delivering it here at UPMC, but it is actually a global initiative. In the corticosteroid domain that I was alluding to, we actually enrolled patients at 121 hospitals at 8 countries around the world. And it's also crucial to getting to information quickly. So coming back to the actual corticosteroid, many of you have probably heard about dexamethasone. This is one type of corticosteroid. And there was a trial published from the United Kingdom earlier this summer that suggested that there would be benefit with dexamethasone. What was going on in REMAP, we were actually testing another steroid, hydrocortisone. It was being given in a very similar dose and in similar patients, critically ill patients. It turned out that with hydrocortisone within our trial, there was a 93% probability that hydrocortisone was superior to not giving hydrocortisone. At the same time, we had colleagues conducting traditional randomized trials in Brazil and France, and actually all of these studies came together, and they were all published yesterday in JAMA. And so after the initial good news from June on dexamethasone, what we did yesterday was really help provide definitive information, and that's in part why the WHO has now issued this very clear guideline on giving corticosteroids, hydrocortisone or dexamethasone, to critically ill patients. This is only possible because of a global community of physician scientists coordinating across different languages, different countries, working together and sharing data at a speed and a level that I think has been unprecedented in order to generate definitive answers. And I feel incredibly proud that UPMC and the University of Pittsburgh was absolutely at the center of that initiative. Now, I do understand, as I already alluded to, that randomized trials can often feel slow and they take too long to generate information. I think, as we've shown with REMAP, that does not need to be the case. We have absolutely been able to generate robust, actionable information at the speed required to respond efficiently in this epidemic. This is part of what we would say is learning while doing. It allows us to arrive quickly at clear guidance on how to treat patients. I would also say it's a way of thinking about how we can have a structure where we're trying to learn from every patient we're treating. So that, for example, in this trial, when someone in Amsterdam agrees to be enrolled in the trial, they produce data that can then help us treat someone in Altoona. This pandemic has shown more clearly than ever why this approach is necessary to achieve speed and to generate effective medicine. Thanks.
Thanks very much, Dr. Marroquin and Dr. Angus. What you say supports what I see daily at UPMC, and that is our COVID-19 patients are doing far better now than at the start of this pandemic. We have a team of gifted physicians and dedicated nurses and other healthcare experts that are doing the things that matter during these trying times. We will use our excellence and we'll leverage all the knowledge that we have and that we find in other locations and the abilities from around the world to help eradicate COVID-19 in all the communities that we serve. UPMC remains ready to care for you and your families throughout this pandemic and beyond, and we'll keep you healthy.
Thank you, doctors. And now we'll take questions from the media, all of whom are joining us remotely. To ask a question, you'll have to go to the participants icon at the bottom of the page and press the Raise Your Hand button. That will put you in our queue. I will read your name and your line will be unmuted for you to ask your question. Please remember to unmute the line on your end as well. We will try to call on as many different media outlets as we can in the time that we have allotted. We do have a few email questions, and I'd like to turn first to Dr. Angus. What are your thoughts on the FDA's emergency use authorization for convalescent plasma and vaccines?
Thanks, Paul. So let me just so that everyone's clear. So convalescent plasma is when one takes from the blood of patients who've recovered from COVID-19, one wants to draw the plasma that contains antibodies that person mounted in order to overcome SARS-CoV-2. And so then the issue is, if we give this plasma to someone else, then we can transfer the antibodies in and we can help that person recover. So convalescent plasma has felt like a good idea for a long time. In fact, there are reports of trying to give convalescent plasma in the 1918 Spanish flu epidemic. The problem is, there have never really been robust randomized clinical trials that actually demonstrate benefit. And so it continues to feel like a good idea. There's strong rationale for it, but we're not actually sure of the benefit. I fully understand the pressure the FDA is under because we can now harvest and make convalescent plasma available. We've actually given convalescent plasma around the United States to around 70,000 individuals. But disappointingly, it's never really been randomized. Actually, here at UPMC, we were attempting to randomize to early versus delayed, and elsewhere in the REMAP program overseas, we are effectively randomized. But the problem about making the EUA available here is that that's actually stopped any immediate attempt to get a randomized trial up and running in the United States. And so now it's going to be weeks at a minimum before we can even start to begin trials. So I would say that the EUA feels like a response to a compelling need, but it's probably only going to slow or delay the speed with which we get to really understand whether convalescent plasma has an effective role to play.
We think that there's great opportunity to improve how it is we bring new therapies, even if they're new therapies behind an old idea, how we do that more efficiently. And an emergency use authorization is one way to do it, but it may not be the most effective way to make sure that eventually we're using the best possible therapies. We want to get better at this. We do not want to depend on a laborious, slow process in a pandemic that requires quick action. We need to be thoughtful about it so that we can continually respond and learn and eventually get better, not just respond quickly and not gain as much information as we might be able to.
Okay. Thank you. Let's go to Paul Goff, Pittsburgh Business Times. Paul, go ahead, please.
Hi, can you hear me okay?
Yes, go ahead, Paul.
Thank you very much for the time. Wondering if you can tell me what UPMC is doing to prepare for the rollout of a vaccine, either one that's being developed at UPMC or will be through CDC, what role the health system has.
So UPMC and the University of Pittsburgh continue their efforts on 3 distinct different vaccine approaches. Those are still ongoing. They're not at human phases yet. You've heard about those in previous press conferences. Secondly, UPMC and the University of Pittsburgh are enrolling and participating in the Moderna vaccination trial that is happening not only in the country but across the globe. We want to be a part of evaluating any very good idea about vaccination. What's important to think about is that vaccines will potentially become a valuable tool in the response to COVID-19. By themselves, they won't likely be the singular changing action or solving issue for COVID-19. They'll be an important part of any response. And you might say, why is that? Not everybody mounts a good response to a vaccination. We'll learn more about it as we participate in these trials. And some folks actually decline the opportunity, and we have to work on that. So there'll be lots of reasons that we can improve on vaccination trials and hope for them to be a part of the solution, but I don't think they'll be the complete solution for COVID-19.
Another email question. We'll get to the media in a minute, but please, again, for those members of the media, please press the raise your hand button, and that will put you in our queue. We'll unmute you, and you need to unmute from your end. So while we're waiting for that, we'll get to another email question. I think this goes to all three. What should people take away from the data that Oscar presented in terms of the severity of the illness? You've said perhaps we're dealing with a lesser strain.
I would say that what we have seen with this disease is that the outcomes that we are seeing are the result of multiple factors. Certainly, there are issues related to the virus and its pathogenicity. There are issues related to the host that the virus infects. And there are also issues related to how we care for our patients. And then lastly, there are issues related to how we as a society behave to try to mitigate the spread and contagion of the virus. And we have certainly seen significant changes in how we take care of patients, for how we have learned, as well as the way that our community has adhered to the recommendations for masking and other things, both of which we believe are among the things that our data show that have had an impact in the improved outcomes that we see in our patients.
Yeah, it's impossible to separate what we do as humans from what the virus does. It depends on us for propagation and for illness. And so the changes that we see are not isolated to what happens in UPMC or any of the communities that we serve. It's been noted around other parts of the country, including New York, that the pattern of illness has changed and appears less severe. In part, that may be due to virus changes. It has a lot to do with what we choose individually to do and how we adhere, has to do with public health interventions, has to do with the tools that we have available to treat. They all play together and there's an interaction. What's undeniable is that there is a change in the clinical patterns. We're not seeing as much severe illness. We still do see severe illness in some, and it has a tendency to be the same types as we did before. Vulnerable people, those who are older or have serious underlying conditions. We need to stay focused on this. The virus changing will not by itself get us away from those important activities as community members or as healthcare providers.
Okay. Let's go to Gabriella DeLuca at WPXI TV. Gabriella, please go ahead.